and we see them come in, particularly cats with ridiculously low PCVs. When it's something traumatic or sudden and they lose a lot of blood, they don't cope so well. And these are the ones that often, even if their PCV is higher, they actually do need a transfusion, even though their PCV isn't that low. And a lot of that is to do because it's an acute loss rather than chronic. So chronic, the body has wonderful compensatory mechanisms that click into place when the anemia is sort of slow ongoing and the loss is slow. And some of them are sort of fairly obvious that happen regardless of the loss of blood. So blood flow gets diverted from peripheries to the main organs. And there is also a clever little sort of enzyme called 2,3-diphosphoglycerate. Get down to the bottom there, you can see it, and that allows blood to be released in the capillaries and the peripheries, allows oxygen from the blood, I should say, to be released at the capillary level, so it helps the oxygen be easily accessed. When animals become anemic, this level starts to rise, but it takes time, it takes several days, and it gradually increases. So when they have a chronic slow anemic loss, this levels rise, so the little bit of oxygen that they have got in their blood is much more easily accessible to their cells, and so you don't see the same level of sort of signs and symptoms of chronic anemia as you do in acute. They tend to cope an awful lot better. This is a little bit, there's been quite a few papers recently using this anemic dog clinical assessment score. They're quite useful, these charts. As you can see, it just goes along from severe, where they're really pale, weak, lethargic, fast heart rate, fast rest rate, weak pulses, to at the beginning where they're still up and about, their heart rate is still fairly normal, their rest rate is still normal, and their pulses are good. And the basic take-home message of these assessment scores is that it's fairly irrelevant in a lot of cases what the actual PCV number is, but what is relevant is how the patient is. So as I say, you can have two patients, one with a much higher PCV, that is really struggling and needs a transfusion, and another that, although the PCV is a lot lower, they don't necessarily need a transfusion immediately. You've potentially got more time to either find and match a donor, or to see if their own regenerative response kicks in and works in it. And they do have transfusion triggers certain sort of PCV points in human medicine that they work on. It's usually about 21% PCV that they will start considering transfusions. Human PCV is fairly similar to dogs. It's sort of 35 to 45. Our dogs are about 35 to 55, cats a bit lower. Oxygenation levels start to drop at a PCV of 30%. And then you see another change when they get down to sort of around 10% or so. Death doesn't usually occur till 5% or lower. So we have seen cats with PCVs of 4 or 5% that are still clinging on. They're pretty ill, but it is possible. But they are very much usually the chronic, slow sort of ones that are going on. So there's your quick talk through of that one. So blood typing. Dogs, as in an awful lot of things, I think, in the veterinary world, a little bit more straightforward. We type for dog erythrocyte antigen, it's a mouthful, 1.1, and they are either positive or negative. So they either have that antigen attached to the surface of their red blood cells or they don't. And that's all that we really test for at the moment in this country. Cats have 3 types more similar to the human typing system. So they are A, B, or AB. There are others, there are a lot of others. Dogs have at least 10 recognised types at the moment, and cats have more, but a lot of them aren't significant or aren't significant in this country potentially. So at the moment, this is all we test for. DAL is present in dogs. Most dogs have it. It's called DAL because there was a Dalmatian that was negative for it and received a transfusion of blood that was positive for DAL and had a terrific reaction to it. Dobermans and Dalmatians particularly seem to be negative for the DAL. At the moment, we don't type for it in this country, but it may be coming. It just depends how things go. Likewise with cats, excuse me, the MIC antigen was discovered in 2007. That's named Mick because it was in a cat called Mike that they had it. And most cats are MIC rather negative, and they will develop antibodies against MIC positive. So you can type them, your AB typing, and you've absolutely, yep, they match perfectly. If there's still a mismatch of the MIC antigen, then you've still got a risk of severe transfusion reaction. So again, it's slowly creeping in some other countries, and tests are available potentially for these things, but we still don't routinely type for them before transfusing at the moment. Cross-matching is the next step. So hopefully most of you will know, in dogs, if you're going to give them a unit of negative blood, you can give a first transfusion without a cross-match. You don't need to type them. You should try and type them, and you should try and type match them because that is best practice if you can. But in an emergency situation or a situation when that's all you've got, you can give dogs a transfusion without a type or cross match. And then you don't need to type match or cross match plasma. The only time you need to type match if you're giving plasma to dogs is if there is a possibility that you are then going to need to give them either whole blood or packed red blood cells, and then it will matter potentially that you've given them a different type of plasma. So again, it's best practice, because you never know which way these patients are going to go, to type match the plasma if possible, but you don't need to, and you certainly don't need to worry about cross matching it or anything in a first transfusion. Dogs, it will take them 4 days to sort of start developing antibodies and potential reactions. So within that 4-day window, you can give them a second transfusion, preferably still the same type blood, but you don't need to cross match it. You can safely give that, and you can give more blood within the 4 days. Once you've passed that 4-day window, then that's different. You will need to cross-match every unit of blood or packed red cells that you give forevermore after that. They will all need cross-matching. And then cats, you have to type for everything, for all products, and even for a first transfusion. There's no such thing as a safe first transfusion in cats the way there is in dogs, which makes everything more complicated with cats. So even if you're giving them plasma, which isn't very common with cats, but if you do, you still need to type that. They have got naturally occurring antibodies, so they have to be type matched and ideally cross-matched even before first transfusion, which is why xenotransfusions are sometimes a good option, which we hopefully will get onto in a bit. But cats, unfortunately, you cannot give anything without typing and ideally cross-matching. And cross-matching, you can send it to external laboratories, but obviously it takes a bit of turnaround time. You can get little kits exactly the same as you get the blood typing kits that you do in-house. They are a bit more fiddly. The first time you look at them, it's a bit, oh, what is this? But actually, once you've done them a couple of times, they are fairly straightforward, and it's often worth just having 1 or 2 in case you do need to do a cross-match. Calculations. So I will sort of skim over this bit fairly quickly. So what we want to do is, in immune-mediated hemolytic anemia, what the literature tends to recommend is that you don't want to give them so much in a transfusion that it suppresses their regeneration of their own cells. So you want to increase their oxygen capability and basically give them a boost, give them some red cells, increase their oxygen carrying ability, but you don't want to suppress anything. So what they tend to say is to aim for a PCV of around 25%. And that is sort of specifically with IMHA, it's not for everything generally. But it's worth remembering when you're doing your calculations that you're not necessarily always just trying to go for the highest or the closest to normal PCV that you can get. Oh, sorry. There we go. The Pet Blood Bank is wonderful. They have lots of things to watch, papers to read, little webinars and things on their website. And they also have some great little calculators and things that will do all the maths for you and work it out. So I would absolutely recommend, if you are not familiar with their website, to get on there and have a look at the different things. If you do want to work it out, then this is how we do it. So we get the desired PCV minus the patient's current PCV and divide that by your donor's PCV. And that gives you the volume of whole blood or packed red cells in mils required. I feel like there's a bit missing off the top of that, because what you're working on is dogs have 90 mil per kilo of blood. So you calculate that, and then I'll show you on the cat one and take it off. So as an example there, dog weighs 10 kilos, desired PCV 25 we're going to aim for if it's got IMHA. It's currently got a PCV of 11. So there's what the bit that's missing from the top. I apologise about that. 90 mils per kilo of blood is what dogs have, times 10 kilo weight, 900. 14 is your desired PCV minus your actual PCV. And then if you're using packed red cells, their PCV is approximately 62%. You can take a little bit from one of the sort of bits of the tubing and test it, but they're normally 62 to 63%. So we usually just work on that figure. So divide it by 62% if you're using packed red cells. And then that would tell you that you would need to give 203 mils to this 10 kilo dog. And then that should hopefully increase your PCV to 25%. Cats, it's exactly the same calculation. It's actually got it up there now. But with cats, depending on what you read, we work on 50 to 60 mils of blood volume. So if I click through it, you can see the example there for a 4 kilo cat. Again, we're just aiming for 25%, same PCV, 62% packed red cells. And in that case, we want 54.1 mils. So as I say, this will be available to you afterwards, so don't worry too much about it. The other thing that you can do is that one. Or, as I say, if you go onto Pet Blood Bank website, it's fantastic. They have a little calculator. You can put your numbers in and they will help you come up with it. But very roughly, 1 mil per kilo of packed red cells or 2 mils per kilo of whole blood will increase your PCV by about 1%. And to be honest, regardless which calculations or anything you do, sometimes they are spot on and sometimes they just aren't, and a lot of that will depend on the animal's medical condition and a lot of other things. So none of this is an exact or a precise science, really. So administration routes, go a bit into that. So either just a peripheral catheter or a central line if you've got one in. You can give blood intraosseous, much the same as you can give fluids. It's particularly useful in little neonates, really young, small animals, and it's actually really quite effective. They will absorb a decent amount through that. It's a little bit slower to be absorbed, but it is still a fairly good route. Intraperitoneal has been written about, I think the general consensus on it is that they absorb less than half of it. It's very slow. It's likely to cause more problems. It's a sort of potential way of getting some blood into a donor, but it's a real do or die situation, I think, and there isn't really any literature out there that recommends that as a route. So your IVC, if you're going to be giving a transfusion, in an ideal world, you will place a new catheter and that one will be purely dedicated to transfusion. It's not always possible in the real world. Veins are tricky to get. So you can use a IV cannula that's already been in place and has already had fluids and meds in. But if you can, try and place a new one. Minimum 25, the bigger the better for obvious reasons. You don't want to risk squashing cells going through, and you want it to be a nice, easy administration. And then if you have got one that you're using for transfusions, it's very important that you label that. We usually just write on the vet wrap that it's for blood only. And then that one can only be flushed with saline. You shouldn't flush that with Hartmann's at all, because it can react with, if you're giving blood, the anticoagulant in the blood can react and cause issues. So label it and dedicate it purely, if you can, to blood administration. I've forgotten what they're called, the little caps that you can get that have sort of a soaked sponge inside with antibacterial on. Ideally use them. Nothing grows better in blood than bacteria. It absolutely loves it. And one of your biggest risks with all transfusions is the introduction of bacteria and issues with that. So you need to be a lot more aseptic and a lot more strict about your protocol with your catheters, about handling, touching them, and ideally you should use these green caps on them instead of just normal IV bungs. Prophylactics, we'll talk about briefly. So all of these things, there have been some papers and some things written, and people have discussed about whether there is any advantage in giving any of these things preemptively before a transfusion. Nothing has come out that says that it is worthwhile delivering them prophylactically. But what I would say is on our sheets, you'll see in a later slide, and when we do it, we calculate all of these doses and we have them ready and at hand. So if there is a sudden reaction, we're not suddenly rushing around to get the meds, calculate them and all of that. So we have them handy, but there's no evidence that says giving them beforehand makes any difference. So quick. This is your equipment list. Oh, sorry, that was a bit too quick, wasn't it? There you go. There's your equipment list for everything, for giving a unit of packed red cells or for defrosting a unit of frozen plasma or fresh frozen plasma. We will go through it. So filtration, obviously you need a filtered giving set or a little filter that you put on. The standard blood giving sets that you get from Pet Blood Bank or the animal care ones, they're the same as the normal fluid ones, the adult fluid ones. They deliver 20 drops per mil, but they've got the little double chamber of the filter. The only thing to bear in mind when you're using these, it doesn't say on the packet or anything, but you need to make sure that your chamber is at least 50% full, and you need to sort of tip it around so that the filter is soaked. And that just makes it much more efficient and effective, and you'll have less problems with the blood flowing through the line. So it's just worth noting that. The other way is to use these little micro filters. So these are the Hemonate ones. Definitely essential usually in cat transfusions, or if you're giving small amounts and you're doing it on a syringe driver, because the standard giving sets obviously aren't going to work, and you just have a little filter at the patient end. Doesn't matter which way around they go, they can go either side. Again, with these ones, you have to use a bit of blood to prime it, and you need to put some in so that the whole of the square of the filter paper is soaked. And you need to do that to make them effective. And the issue with these is that you can only actually put 50 mils through. and then you need to change them. And ideally, in a transfusion, you never break the line once it's started, because then you risk introducing bacteria. So the issue with these is if you're giving more than 50 mils, you have to keep changing them. 20 mils is even less with packed red cells. There is a much better alternative, which is these little ones, SA150s. They're vet specific. You can get them from the Pet Blood Bank. I don't think you can get them from other suppliers, but I'm not 100% sure. But they are a lot better because you can get 250 ml through them before you need to change them, which in an awful lot of animals is about the amount of transfusion that they will have anyway. And again, bidirectional, we usually put them at the patient end. You can put them anywhere in the line, so long as they're in there somewhere. We just usually find it easier to put at the patient end. So a little chat about using infusion pumps or gravity flow. Again, an awful lot of people have looked into this, and there's still debate about it. You absolutely can use infusion pumps. A lot of the companies that make infusion pumps, they've done studies, they've looked into it, and they have evidenced that they do not burst the cells, which is what they were concerned about, that the actual pump action was hemolyzing the cells as they go through. You need to just make sure that the ones you have got, check with the manufacturer that they have been licensed for blood cells to go through. Plasma, it's fine, it's just the cells that are the concern. But what research has shown is that although it doesn't hemolyze the cells, it causes a bit of a shearing effect on the cell surface. So although the cells are still effective and it works, they will probably be destroyed, identified and destroyed by the body's immune system faster than if they go through by gravity flow. So most cases, it's not too bad. They're still going to last long enough to hopefully till the patient can start regenerating their own cells. But in some cases where there isn't regeneration potentially, it's worth remembering that likelihood is those cells will have a shorter lifespan because they've gone through the infusion pump. Gravity flow is difficult sometimes to work out and to get it to run. And if you have a smaller animal, by the time you've counted the drips, it's time to change again. So it is quite difficult. So we do tend to use infusion pumps for most of our transfusions. But again, it's a clinician's decision, case by case. And obviously syringe drivers, smaller patients, gravity flow is virtually impossible to count drops if you're giving some to a cat. So we use syringe drivers with the little filters on, and they work well. So this is warming your units. So plasma obviously comes frozen, fresh frozen plasma or frozen, and needs defrosting. You have to be, again, really strictly aseptic about this, and you need to have dedicated equipment, and you need to warm them to ideally sort of body temperature. There are risks associated with giving cold products, so particularly with blood, if you're giving it, it's not frozen, so you don't have to warm it up. But if your patients are already hypothermic, if they are really ill, if they are older or younger, it's definitely worth warming up, because just reducing that temperature a bit when they're already potentially very sick, you can increase the risk of coagulopathies and heart arrhythmias, and the cells simply will not function as well. So ideally warm all products, but obviously you have to defrost plasma. You can get little commercial warmers, just check that they are giving you the temperature that they say they are, or you can just use a washing up bowl and a thermometer and check it that way. As I say, dedicated equipment. Don't go and grab a cat litter tray or something and use that. There was a case of a patient catching Pseudomonas, and it was traced back to the fact that it was just a litter tray that had been used for cats, and then they defrosted a unit of plasma in it. So don't do it. If you're going to have it, have absolutely dedicated thermometers, dedicated everything, and treat everything aseptically when you do it. Don't use a microwave, hopefully. Hopefully none of you would. You need to put them in a sealed Ziploc bag. And again, really, that's just to try and keep it as clean as possible and contained. And then your water in your bath or your washing up bowl or your clean dedicated litter tray wants to be sort of 33 to 37. It doesn't matter so much the lower end, but if you get it between 33 and 37, and you will have to keep refreshing that water, it should take about 11 to 15 minutes to defrost a unit. So it's not a long time, and it will take you that long to get all your paperwork sorted out and everything else set up ready. It is very important that you don't go above 37 degrees because you will start to damage all the proteins and hemolyzed cells, and it will make your unit not as effective. So it's really important that you, if you're going to have to change the water, take the bag out, tip the water out, refresh it, check it with a dedicated thermometer, and then put your unit back in. Don't ever sort of run hot water onto it or anything. And then preparing the unit, it's exactly the same as any other IV fluids, but it's a bit fiddly because it's a soft bag. You just have to be careful when you're inserting the spike that you don't accidentally stab the side of the bag. And again, you have to be really much stricter with this than you would normally be with IV fluids. So wash your hands, wear gloves, make sure the end of the unit doesn't touch the floor or anything like that, and keep the cap on till the very last second when you're going to attach it, because you honestly can't be too sort of sterile with these units, particularly blood, because as I say, bacteria just loves it, so try and keep it away. Safety checklist. Hopefully a lot of you are familiar with this, use them for other situations in practice, such as theatre safety checklists certainly seem to be done in most practices now. It's 2 people we use, and we have someone double check all the calculations. So whether you can see there on that sheet, done the calculations, how much blood we need, what rates it's going to go in, what we're going to give, who we're going to give it to. I mean, I've had to cross out the name there, obviously. And then you verbally read these out to someone else, get them to confirm everything, and then they countersign it. There's an awful lot of mistakes in the human world, unfortunately, with transfusion medicine. We do it less frequently in the veterinary world. It's very rare that you'd have 6 animals on a ward that are all having transfusions, and you might mix up their blood types. But it's still good practice to have just a safety checklist and have someone double check everything, and just make sure you both agree and happy with everything before you go ahead and start that transfusion. Rates, standard, you can find these in an awful lot of literature. Again, it's on the Pet Blood Bank website, so I won't go through it too much, but normally you go up to sort of 10 mil per kilo per hour with dogs after you've gone through the initial bit if you've got no transfusions, and then again with cats you can put it up to that, but we usually go a bit lower with cats, sort of 5 to 10 mil, but we're usually on the lower end. And cardiac patients, you have to be careful and don't go above sort of 4 mils per kilo per hour. Obviously, with some of these, if they're on a slower rate, ideally, once you've broached a bag of blood or any blood component, you want to have given that full transfusion within 4 hours. And the reason is that is simply because the bacterial load after 4 hours increases dramatically, and therefore the risk to your patient increases a lot. With patients that are at risk or that have had or starting to have reactions and you have to slow that rate down, just agree between yourselves and get your clinician to check first that you're okay to continue it. We often do have to give transfusions over, say, 6 hours in order to get the full amount in safely. And it's not the end of the world, but again, you're going to need to keep a close eye on those patients for any signs of infection or issues afterwards, but you can go for longer than the 4 hours if you need to. I've just put in here some more lovely calculations. if you need to work it out for gravity flow. Hopefully you will remember doing this for your exams when you have to do it for fluids. It's very much the same, but as I say, these will all be available to you afterwards, so I won't go through this too much. Monitoring sheets. You can make your own. You can print brilliant ones off the Pet Blood I can't say it tonight, Pet Blood Bank website. We've done a combination of both, really. We've used a lot of the information on theirs, and then we've added in our own safety checklist, and we've added in sort of pre and post transfusions, and just a little bit about, have you ordered more blood and priced and this. But make sure you concentrate and you've got good monitoring sheets, because if you are starting to have any problems, you will really want everything clear and detailed so you can look back at it. If you've got a multi-parameter monitor, it makes your life so much easier. You don't have to disturb your patient. When you're taking the temperature every 5 minutes of patients, they can get quite fed up, particularly as they start to feel better, and it makes things difficult. If you've got a multi-parameter monitor, particularly one that's got a sort of indwelling thermometer, it's wonderful. You can just set it off and then be fairly hands-off, which is much nicer for the patients as well. Form any changes, as you can see the bit on the bottom where it all says no or increase is has there been any changes or anything happening, and obviously as soon as you get any changes you need to let your clinician know and make a decision about how significant you think those changes are. It's just a close-up. And then transfusion reactions. So there's acute and delayed reactions, and there are lots of different ones of delayed reactions which can occur from sepsis and from having too much anticoagulant and all of these things. All we're going to look at the moment is the sort of acute reaction that you're going to see during the transfusion and what you need to look for and what you need to do about it. So they can just be very mild, you're aware of it, but you can still complete the transfusion, or they can be very severe and potentially fatal. So early detection has been proved as the one thing that is really important for having a positive outcome if you do have a reaction, which is why you need this really intense monitoring and you need someone sat one-to-one with them for the entire transfusion. Oh, sorry, that's not easy to read, is it? So typed, cross-matched, correctly stored and administered blood products, you've actually got very, very, very little chance of a reaction, and it's a fairly long 4 hours sitting there just writing that everything's fine each time and going through it. But that's why you do all these things, to ensure that you don't get reactions. Oh, so sorry, that's not good to read, is it? So you can get immunological reactions, which are your hemolytic reactions and hypersensitivity, and they are sort of antigen driven, and they activate complement, which is the sort of cascade of immune reactions that cause all the signs that we see. And then obviously your other ones, as I say, which we're not going into, but which you can also get, a potentially sepsis, circulatory overload, and toxicity from the anticoagulant. So acute is defined as within 24 hours from the start of the transfusion. Most of the time, I would say, if you're going to get a reaction, it does happen fairly early on in the transfusion, but technically anything occurring within 24 hours from when you start that transfusion is defined as acute. And delayed, which we're not going into, is over 24 hours. That's a bit easier to read, isn't it? So acute hemolytic transfusion reaction. This is the biggie. This is the one that you're sort of looking out for and doing all your checks for. So this is where the red cells hemolyze pretty quickly by antibodies in the recipient's plasma will attack them and destroy them and cause big problems. And this is what happens with cats in a first transfusion if it's the wrong type, or with dogs having multiple transfusions if you haven't cross-matched them. And you can see, I mean, I don't think you'd see all of these signs, but you can see any combination of these occurring and in differing severity depending. And likewise with cats, if you give type B cats A or AB blood, this is the reaction that you get. There we go. What do? You stop the transfusion. You get your clinician, probably going to give antihistamines, probably going to give steroids. A lot of them, if they're IMHA particularly, are already on steroids. Maybe vasopressors if you're having real problems and your blood pressure's tanking. Fluids, if we're not already on them. And then you've got to decide if you're going to continue that transfusion. It's very unlikely you are if you're having this, because it's a real risk to life. But then if it is that animal's only chance, maybe if you were going to, you would have to slow right down. But it's unlikely, if you're seeing signs of this, that you should continue that transfusion. And then we have this one, which is the immunological hypersensitivity transfusion reaction. So again, this one can be much milder. It's more of a sort of hypersensitivity. So it's like when they get an anaphylactic reaction to insect stings or reaction to vaccines. It goes along the same sort of pathway as those. They'll come out in hives, get edematous, red skin, vomiting, diarrhea, fast breathing, fast heart rate, and their blood pressure will drop. What do you do with these? Exactly the same. Stop the transfusion, get your clinician, antihistamines in there, steroids, continue the transfusion. These probably you could, if you're going to give them a little bit of time, give the antihistamines and the steroids. If it's not severe, then again, slower rate, much slower rate with it, but you could potentially continue this transfusion if you needed to. And the other one which you need to be aware of, which when you first start seeing the temperature go up, is a bit of a worrying moment, and you're like, oh, what's happening here? My temperature is going up. You get it just at the beginning of the transfusion or within the first couple of hours. And you will always get this. Cytokines get released from white blood cells in storage, and they will be recognized and they will trigger a little bit of a reaction, because no matter what, it is a foreign substance that you are putting into their system. So there will always be a very little reaction. And what you get is just an increase of temperature, usually sort of up to 1 to 2 degrees is okay. Anything, if it's getting above that, is a little bit more worrying. But if the temperature's just going up by 1 or 2 degrees or so throughout the transfusion, it's fine. If it's going high, you can give something to bring it down. You can give paracetamol, you can give them active cooling, or you can slow down the rate. But it's not a reason to stop the transfusion. You can continue with that febrile reaction. And then post-transfusion monitoring. You still need that person to sit with them for about an hour afterwards, just to make sure everything has been okay. And then this varies entirely, again, clinician's choice. We tend to go within the first hour of the transfusion finishing. We will take a PCV and check it, and then depending on the case, 12, 24 hours after that. But some people like to leave it for longer before testing it. It just depends. And then obviously you have to note the colour of any serum if you take blood samples or anything, because if they are hemolyzing and you're starting to get that showing, then that's significant, and you would need to know that. And again, with your IV port, flush it with saline, use your disinfectant caps, and use it only for blood. And then just continue supportive care as you would, depending on the case. So xenotransfusions, we'll talk a bit about these because they are actually quite often the only practical option, particularly in an emergency situation. So they've been done in lots of different animals. They even did try them in humans with animal blood, but there's not really a need for that anymore. Obviously, the one that we usually see and talk about is giving canine blood to a feline recipient. So the reason why we end up doing this is because cat blood is difficult to source and collect. So both in terms of the ethics of feline blood banks have been debated a lot over the years, and sometimes there are some in the country, but they tend to have very scarce resources. There are some abroad, but there is a lot of difficulties with how they're kept, whether they're colonies purely for donating blood, whether they're allowed outside access. It gets quite difficult. So it is harder to get hold of cat blood. Pet Blood Bank currently at the moment does not stock it. I know they were certainly looking into it, and then I think the whole COVID thing happened, but I think they probably are still looking into try and do that. And there are some places that you can get it from, but generally, if you need cat blood, you end up trying to find a donor, and if that isn't possible, a xenotransfusion is a viable option. If you're going to get your donors, again, there's a whole list of criteria that they need to fit. And then there is the added risk of, there is always the worry of any occult heart disease. So ideally, they would have echocardiogram, they would be blood tested, vaccinated, flead, wormed, if possible, indoor only. And most of the time, they are going to be a relative of the cat that's in, if they're going to be suitable, and in which case they live together anyway. So you don't need to stress too much about these bits. But if you were looking to sort of bank feline blood, that's why it becomes so complicated, because there is an awful lot of testing that they would have to go through, such as mycoplasma and rotavirus and all sorts of things. So they also quite often obviously need sedating. That's a risk to the donor, which is something that needs to be taken into consideration, and then donor aftercare. So even if, for example, the owner does have another cat or a relative of the cat that needs blood at home, you still have to discuss potential risks to that cat, and it's just not always suitable or possible. Pop through there. An AB is very rare. So if you've got an AB cat, trying to source an AB donor in the time frame that you probably have is very, very difficult, because they are rare. So a quick bit about feline blood types. We've already discussed AB, and a bit about the MIC antigen. They did do a study in 2014 in the UK, and they didn't find a single MIC negative cat in the UK, which I think is really why we aren't testing for it at the moment. It's more prevalent in America, but I don't know how many cats were in this study, I don't remember, but they didn't find a single one in the UK. So as I say, at the moment, we're very much just AB, AB and AB. So type B cats have a high titer of strong anti-A. So they are at risk of a severe hemolytic reaction immediately if they are given A or AB, and that could potentially be a fatal reaction. Type A cats, they have a low titer and a weak anti-B. So what they tend to get is a delayed hemolytic reaction if they're given B blood. It's not usually as severe, not such a risk of it being fatal, but they do still get a reaction. It's just more of a delayed one. And type AB is really, it needs type AB. You're struggling with those, as I say, they're very rare. They haven't got antibodies to either. So you need an AB donor, or you can, it gets complicated if you have type A packed red cells, but you have to give packed red cells. You can't give plasma, because that could potentially have anti-B antibodies. So AB cats are just complicated when you get into it. So as you say, transfusion risks, you can't just give them a transfusion. You've got to type and cross-match, because they have naturally occurring antibodies, and they will destroy transfused cells pretty much straight away. There's just a little table with your donor and your recipient of blood types, and as you can see, potential fatal reactions with giving BCATs type A or type B. So the other option is a xenotransfusion. It is really only suitable in an absolute acute emergency setting. So realistically, where a cat is so ill that you just don't have the time to try and find banked blood or a suitable donor, or if the owner has no other cats, you don't have any cats on the list if it's type A, B or something, and this cat is imminently critical, really low PCV, then it is a suitable option. So tested incompatible, previous reactions, cost issues. I mean, if you're having to get cats in, you have to type them, you have to test their blood for any viruses and diseases, you have to scan them, you have to sedate them, you have to put them on fluids. It is expensive, potentially, depending, it may work out more cost effective to the client to use canine blood if you keep it in already. Short-term stabilization, it's not as good as giving typed matched feline blood, but it definitely buys them some time. And it's not really suitable for sort of non-regenerative anemias and these really chronically ill ones. It's very much, as I say, in the sort of emergency setting with cats. And they cannot ever have a second xenotransfusion. There's no exceptions to that rule. They can have a small amount of dog blood once, and that is it. You can then buy yourself time to find a donor, type it, test it, match it, and they can have that typed matched cat blood, but they absolutely cannot ever have a second xenotransfusion because they will have developed antibodies to it, and they will have an acute hemolytic reaction if you give them a second one. So it doesn't matter what blood type you give, DEA1 positive or negative, it's made absolutely no difference because it's all foreign to the cat anyway, so it makes no difference. There have been some cases of an acute hemolytic reaction, but they are very rare. I've never seen one, and we have done several here, but there are some documented that have been seen. What you will get, no matter what, is a bit of a delayed hemolytic transfusion reaction. And there isn't any way around that. You're going to get that. Cross-matching doesn't really help either. It's not a reliable indicator. People have done studies where they've cross-matched and it's just made no difference. The blood's either been okay or it hasn't, regardless of what the cross-match has said. So that doesn't help either. Owner consent, because obviously it is quite a high risky thing, so you need to discuss it, and you also need to discuss that there is going to be an increased level of hemolysis from this delayed reaction. They will break down the cells in about 4 to 7 days. Normally, if you're giving typed matched cells, you're potentially going to have up to 30 days with these cells. With xenotransfusions, they will break them down in a few days, so you will get problems with hemolysis, and you do need to make owners aware that that is a risk. So it's exactly the same sort of guidelines in terms of rate that you give and how you give it. The only thing that is different is where you would normally calculate your amount with those sums we had earlier. You don't do that with a xenotransfusion. You want to give them as little as possible because it is dog blood that you're giving, and they are going to break down those cells and have hemolysis. So you want to give the smallest amount you can get away with. I think it's the International Feline Medicine. They did a whole big study on it, and they have brought out guidelines. There was a very good paper all about it. And what they say is ideally minimal amount, no more than sort of 25 mils of packed red cells, or if it's whole blood, 30 mils or so. And you don't want to go above that regardless of the PCV, because you may cause more problems than you're solving by giving that. As I say, cross-matching, don't bother. So you won't get, hopefully, an acute hemolytic reaction, but you will get a delayed hemolytic reaction. So it is very much a temporary solution in regenerative anemia, and that's often when we've used it. We've given them just 20 mils or so of canine red cells, and it has bought us enough time to type and test and scan and get blood from a donor, a suitable donor, and cross-match it. And as I say, you then can go on and give donations, or sometimes it just buys them enough time for them to recover themselves. It depends entirely on the situation. No second xenotransfusion, absolutely ever. No way around that. And as I say, the red blood cell survival time is only sort of 4 to 7 days. It could be less depending on the severity of the reaction they have. Right, we haven't got long. I'll quickly whiz a bit through autologous transfusions, trying to cram it all into one evening. So this is a lovely solution. Various times that it gets used. A lot of the time it's done preemptively in major surgeries where blood loss is anticipated, or if there is potentially some religious reason from the owners to not give homologous or xenotransfusions. And then, as I say, you can plan ahead. If you think you're going to lose a lot of surgical blood, you can collect it in advance, or if you're doing clever things like autologous blood patch porodesis, which we will not go into. What we're really going to talk about tonight is direct reinfusion. So these are your cases that are sort of really bleeding out, and you potentially haven't got banked blood in-house or way of doing it, and your patient's losing all this lovely blood. And this is just a quick practical guide of how you can, as safely as possible, just put that blood back into your patient and use their own blood as a transfusion. So there's a couple of ways you can do it. You can do it with your pools tip and a suction unit. If you've got a way, ideally, of sterilizing your suction unit, you can just do it with a needle and a syringe, or just a syringe, depending on the circumstances. You may or may not need anticoagulant. We'll do that in a minute. And we'll have a quick discussion about risks with hemangiosarcomas and possible spread from tumours. Other things, if it's a trauma case, there is the risk of contamination. So we'll quickly whiz through how to check for that. So your contamination risks. So often, as I say, in sort of traumas, RTAs, or they've fallen on a fence, or they've been kicked by something, there is obviously the risk that there's been damage to an internal structure, the bladder, the gallbladder, any of those things, and you may not be aware of that yet, but there may be things leaking into the blood which you would not then want to put back IV into that patient. So you have bilirubin in there, all of these things, and these are all tests that you can run on the blood, take a little sample of the blood, and then do a quick smear and just rule out that these things are potentially going on. So to get a bit of blood from your abdomen, and then you've either got, hopefully, your lab machine or even a dipstick, and it's as simple as, if your bilirubin is much higher than the blood intravenously in that dog, then there's a risk of a damaged bile tract or a duct. If the BUN or the potassium is much higher than in the blood of that patient, you've got a risk of a urinary tract or bladder rupture. And the blood glucose, if it is about 1.1 millimoles per litre higher or lower than your normal blood glucose, then there is a risk that there is bacteria and that there's been some damage potentially to the GI tract. And you can also confirm that by doing a quick blood smear and just checking for any bacterial contamination. And if you are at any risk of any of those things, then it is not suitable for an autologous transfusion. So, brief list of equipment. If you've got it, ultrasound, 3-way tap, sterile, syringes, needles, extension sets, anticoagulant, which you may or may not need, and syringes potentially already pre-filled with your anticoagulant, again, depending whether you're going to use that or not. And then you still need to filter it with a giving set or a little microfilter, because there's still going to be fibrin, clots, risk of debris in there, so you still need to filter that blood. So if you've got the ultrasound, it's lovely. It's as simple as going into the site of bleeding, large gauge catheter. If you haven't got ultrasound, they recommend going about 3 to 5 centimetres lateral to the umbilicus. And point the needle caudally, so you're not going to jab anything serious in there. Gentle aspiration, because you don't want to hemolyze those cells as they're coming out. And then anticoagulant. So the anticoagulant thing, if you do need to use it, then it is 1 ml of anticoagulant to 7 ml of blood. And what you do is you get your 20 or 30 ml syringes, depending on the size of the patient and the amount of blood you're likely to get, and you pre-fill them with the correct amount of anticoagulant before you draw it up. And then you know that you've got that blood okay in there. You don't always need to use anticoagulant. Again, it's clinician's choice. I think it talks about it a bit later, but essentially if blood has been in contact with pleural surfaces or abdominal surfaces for an hour or more, it's not going to clot, so you don't need it. Where you have to be careful is if there is ongoing bleeding, then you potentially would, because you'll just have syringes full of clots which are unusable. So hemothorax centesis collection, you're going to go in just as you would with anything, 7th to 9th intercostal space. Again, as you see, 45-degree angle, 3-way tap. The little extra one that you can't see can either go off into a little collection bag. Sometimes, depending on the patient and the whereabouts and how it was, you just collect it in syringes and line them up. Sometimes you do it that way and collect it in a little bag with or without anticoagulant. It just depends on the circumstances and the size of your patient. And then direct your needle cranioventrally and see how much you can get out. So perioperatively, this is where you've got them open, literally, abdomen swimming full of blood. You can just go in there sterilely with your large syringes and collect it. And we have literally done that, where you draw it up in large syringes and then you put a filter on the IV of the patient and you're literally giving it straight back into them immediately. And it's not the ideal way, and it's a bit messy. But if your patient is losing that much blood that their life is at risk, it's certainly worth a try. You can collect it and put it in a collection bag and then hang it up and run it through. Or as I say, you can use a pool tip and a sterile suction unit preferably. What you do have to be careful with if you're doing that is that the tip needs to be fully submerged of your pool's tip, so it can't, the abdomen has to be really full of blood. If it's sort of causing it to foam and bubble at the surface, it's going to cause massive hemolysis and isn't going to be worth using. And your suction unit, absolutely not above 100 millimeters of pressure. Ideally below 60, because again, anything above that, you're just going to damage the cells so much that it's not really worth doing. So you've got to have your tip fully submerged, ideally less than 60 millimeters of pressure, and then you can collect that blood and reinfuse it. Filter it always. So benefits, you've not got to type, you've not got to cross match, they're not going to have a reaction. There is the risk that they might get sepsis or something if it's not very sterile, but they're not going to have an antigen-driven reaction to this. It is fairly cheap if you think of the equipment used compared to having to buy in blood and other equipment. Nothing really specialist. You can get very specialist equipment, but you can just do it as basically as I said if you need to. And it's pretty fast. As I say, you don't have to do this 0.5 ml per kilo for the first 5 minutes and then increase it and so on. You can just whack it in because they're not going to react to it. So it's fine. Some risks: contamination, as I said, the things that we've been through. You can get clots in there, little fat emboli. So again, you filter it, but there's still risks with it. Neoplastic cells. Again, there's a lot of debate. It's really a case of discussing with your owner and your clinician, deciding sort of whether it's worth the risk, because there is the possibility, but now the life expectancy of patients with a hemangiosarcoma, if that's what it is actually much less than they used to think. So it may still be worth it if potentially you're going to lose this patient on the table, but it needs discussing and explaining with owners. And as I say, every clinician will feel differently about those risks. Leukocytes, so white cells, you also, obviously, you're transfusing all the blood back in, including the white cells. If you have lovely devices that filter all these out, like cell salvagers, then that's wonderful. You can get rid of that risk. But you will have much higher levels of cytokines, which we mentioned earlier, and they are little proteins, and they are what basically trigger your immune system into sort of a cascade of reaction and give you high temperatures and potential issues with that. And the more sort of white cells and damage to white cells and storage of white cells, the more release of this you get. So there is a risk with that. Hemolysis, obviously, you've got to be gentle with how you're doing it. Don't do it too quickly. Use the right size needles and syringes. Cytokines. An activated complement. Again, this is your chain reaction of transfusion reactions. And they have seen in some human studies that it has somehow been triggered by their own blood, but there is not a lot about it, and there is not any papers involving veterinary patients regarding that I'm aware of. Any other risk, if you are using anticoagulant, is potentially making your patient hypocalcemic because of the anticoagulant, and then obviously you've got risk of seizures and heart issues, so that's one to be careful of as well. Coagulopathies, again, depending on how the blood is and how you go through it. Reinfused blood does have an increased risk because chances are it's already used all of its clotting factors, so it hasn't got any more left. So although you volume expanded with blood, it's not got all the capabilities that you would like it to have because it has exhausted its factors. So you can get, I won't go into it too much because I appreciate that we've overrun, I apologise. You can get lovely cell salvage machines. I was going to say, but I won't go into them. They do wonderful things. They collect it and they filter out the white cells and any debris and any complement, anticoagulants, medications, and the ultrafiltration ones will also remove neoplastic cells. And then you are just left with sort of red blood cells with a PCV similar to that of a bag of packed red cells. So if you use those, which is what they have in human medicine and in potentially some bigger hospitals, then it's wonderful. You've not got a concern about reinfusing your patient's blood. But the scenarios we're talking about is more your general practice and your emergency situation where you need to do it. So yes. Sorry, I'm a bit late, but I have finished. We can take some questions equally. I appreciate everyone has probably worked all day and wants to get on. So my email will be available. If you have any questions, please feel free to email me or Ellen, and they will get to me and I will get back to you. Thank you very much.
There's just one question being put in the chat, Alice.
Yeah.
That Hazel put near the start. I've asked if she meant just in general or if she means in a transfusion, but she's asked how often do you recommend changing a catheter? So I'm not sure if that's transfusion or just general nursing.
So exactly the same with transfusion as in general nursing. If there is any sign of any phlebitis, then you need to change that. If not, it varies slightly depending on who you ask and which catheters you use, but generally up to about 4 or 5 days, and then ideally replace them. In some of these patients whose IVs are so fragile, if there's no phlebitis and you're checking them regularly, potentially you can leave them in up to 7 days. It just depends. And again, if you've got a central line in there, they can stay in for a bit longer, providing you're checking them and they've not got any phlebitis or any problems.
I mean, that's pretty much everything that we've got in the chat. There's a question, will they be able to have the link for the recording? Yes, I have recorded the whole session, and I'll be able to send it out on email. If anybody specifically wants it on email, just let me know. Obviously, I'll send everybody a CPD certificate tomorrow, and it will also get uploaded to our website. So there's a CPD library on the Swift website, so I'll be able to pop it on there as well so people can access it. But otherwise, I can't see that there's any other questions. Everybody just says thank you very much, Alice. That was very informative. So lovely. So we'll wrap it up there then.
All right. Thank you very much, everyone. As I say, if you think of anything, feel free to email through to me or Ellen, and we'll get back to you. Good night then.
Perfect. Thanks, everyone. Bye.